హాయ్ ఫోక్స్, వెల్కమ్ టు మై ఛానల్ ది యావరేజ్ డర్మాడాక్. ఇక మొదలెడదామా? Before going to discuss about Langerhan histiocytosis, let's see what is histiocytosis first. Group of diverse disorders with a common primary event. What is that primary event? Accumulation and infiltration of histiocytes. This is not because of any pathology. What are histiocytes? Large WBCs resident in tissues. Bone in bone marrow under the influence of certain cytokines becomes antigen presenting cells, and some may also attain phagocytic capabilities. Like every other blood cells, these are also WBCs born in bone marrow, but because of certain cytokines influence, they become antigen presenting cells with some of them having phagocytic capabilities. They come and settles in tissues. Then they are called as histiocytes. Skin histiocytes settled in skin. What are they? Langerhan cells with immunohistochemical marker CD1A S100B CD207, also known as Langerhan CD45. It settles in epidermis. It is a antigen presenting cell. Next, macrophage. I already told all are antigen presenting cells and some may have phagocytic capability. This macrophage has phagocytic capability. Immunohistochemical marker CD45, CD68 and lysozyme. It settled in dermis. Next, dermal dendritic cells. Immunohistochemical marker same, CD45, CD68 like macrophage. Only difference is factor 13A. It also present in dermis. Langerhan cell histiocytosis has various other names. Langerhan cell granulomatosis, eosinophilic granuloma, Hand-Schuller-Christian syndrome, Hashimoto-Pritzker syndrome, non-lipid reticuloendotheliosis, Lecterer-Siwe disease. Remember like this two granulomas: Langerhan cell granulomatosis, eosinophilic granuloma. 2H, Hand-Schuller-Christian syndrome, Hashimoto-Pritzker syndrome. Non-lipid reticuloendotheliosis, Lecterer-Siwe disease. Coming to definition, it is a rare inflammatory neoplasia of myeloid dendritic cells, characteristically CD1A S100B CD207 positive mononuclear cells with bean-shaped nuclei. Morphologically and immunohistochemically resembles specialized dendritic cells of skin known as Langerhan's cell. Electron microscopic image of Langerhan cells. It has dendrites, Birbeck granules in cytoplasm. These granules are rod-shaped or tennis racket-shaped granules. Next, coffee bean-shaped or kidney-shaped nuclei. This is the electron microscopic image of Langerhan cells. Coming to epidemiology, more common in whites, males and in age group 0 to 15. Male is to female ratio being 2:1. It can occur in all age groups but most common in 0 to 15 years. Etiopathogenesis. Prior there is a discussion as it is a reactive disease or neoplastic disease. Now in genes like BRAF V600E MAP2K1, they observed some mutations and confirmed this disease as a neoplasia with ERK activation and gene mutation, BRAF and MAP2K1 genes. If ERK activation occurs in immature myeloid cells, then it affects multi-organs. If ERK activation occurs in a more mature or differentiated cell, only single organ will be affected. These neoplastic cells secrete osteopontin, vannin and tumor growth factor beta, which attracts eosinophils, macrophages and activated T cells. Coming to classification, if only one organ is affected, single system; more than one organ, multi-system. Most common organ affected is bone. Some organs are considered as high risk organs like bone marrow, liver and spleen. If these organs, any one of these risk organ is affected, then the disease will have a worst prognosis. Coming to clinical features, if skin gets involved, small translucent rose yellowish crusted papules, vesicles, pustules on trunk, intertriginous areas, scalp, associated with eczematous scaling which resembles intertrigo or seborrheic dermatitis in adults, cradle cap in infants. It affects scalp, so it may resemble seborrheic dermatitis in adults, cradle cap in infants. It affects intertriginous areas, so it may resemble intertrigo. It affects seborrheic areas, so it may also resemble diarrheal disease. It comes under differential diagnosis. If the disease is more active, hemorrhagic papules, nodules with petechiae or varicella-like eruption may also occur. Coming to nail changes, onycholysis, subungual hyperkeratosis, paronychia, nail fold destruction, pigmented or purpuric striae on nail bed. These are all nail changes of Langerhan histiocytosis. Mucosa, most commonly nodular ulcerative lesions around perioral, perigenital and perianal areas. Coming to oral cavity, most commonly we will see intraoral mass, gingivitis, loose tooth and mucosal ulcers. Now, non-cutaneous involvement. Bone is the most common organ, already I told. In bones, which is most commonly affected is skull. Patients presents with localized tender mass. If we take an X-ray of this mass, bones will reveal lytic punched out appearance in X-ray. Lymph nodes, most common lymph node affected is cervical. Then mediastinal. If mediastinal lymph node gets affected, it will lead to asthma-like features. If bone marrow gets affected, it will lead to pancytopenia. Liver and spleen, hepatosplenomegaly. Because liver is affected, it will lead to hypoalbuminemia, ascites, cholestasis, cholangitis, sclerosing cholangitis, and clotting factor deficiency. Cholestasis, sclerosing cholangitis, clotting factor deficiency. Coming to lung involvement, cystic or nodular destruction of lung tissue occurs, which leads to chronic cough, shortness of breath in some. Some may remain asymptomatic, and on X-ray there may be an incidental finding of nodules inside the lungs. In CNS, neurodegenerative symptoms like ataxia, dysarthria and cognitive dysfunction may happen. Coming to endocrinopathies, most commonly it affects hypothalamo-pituitary axis. So most commonly patients may present with diabetes insipidus. Anterior pituitary hormone deficiency, if it occurs, it will be permanent. GI affection is rare. If GI gets affected, it may have malabsorption, hematochezia, perianal fistulas and diarrhea. How we will diagnose this disease? Histopathology reveals dense and band-like infiltrates of the papillary dermis with pathological Langerhan cells, which are 4 to 5 times larger than lymphocytes, oval-shaped with eosinophilic cytoplasm and kidney-shaped nucleus, admixed with variable numbers of neutrophils, eosinophils, plasma cells and histiocytes. Already I told you, these neoplastic cells, which are pathological Langerhan cells, they secretes osteopontin, vannin, tumor growth factor, beta, which attracts these inflammatory cells, neutrophils, eosinophils, plasma cells. It will be absorbed in early lesions. If lesions become old, macrophages and fibrosis becomes more prominent. Coming to immunohistochemical markers, already I told you, CD1A, S100B, CD207. One more addition, peanut agglutinin. In electron microscopy, these pathological Langerhan cells reveals Berbeck granules. If we see Berbeck granules, then we can diagnose it as a definitive diagnosis of Langerhan histiocytosis. Coming to differential diagnosis, already I told you seborrheic dermatitis, diarrheal disease, intertrigo, candidiasis, scabies, varicella, malaria, because it may have vesicles. Folliculitis, Urticaria pigmentosa, lichen planus and lichenids. It may also have papules. Multiple myeloma and mycosis fungoides. Remember 3 M's: malaria, multiple myeloma, mycosis fungoides. Coming to treatment. If only skin is affected, as a first line, topical steroids, second line, topical nitrogen mustard and PUVA. We can also give tacrolimus, thalidomide, imiquimod, isotretinoin, methotrexate, excision and intralesional steroids. If bone is affected, we can do curettage, which acts as both for diagnostic purpose and therapeutic purpose also. Then radiation. If multi-organs are involved, prednisolone and vinblastine as a single agent chemotherapeutic drug. Then biologicals against CD1A, CD207, because pathological Langerhan cells are positive for CD1A and CD207. Remember the channel name, The Average Dermadoc. Like, share and subscribe. Thank you. Hasta la vista. Desvidania.